All right, let's get right into it. Today, we're pulling back the curtain on what it really takes to ace your surgical practical exams. This isn't just about what's in the textbook. This is insider advice, straight from a senior surgery professor, on all the common mistakes students make and how you can avoid them. We're going to totally reframe your approach.
So let's start with the big one, right? What's the secret sauce? You've done the work, you've memorized the facts, but what's that extra something that makes an examiner sit up and think, wow, this person gets it? What really separates the good students from the truly great ones?
And here it is. The answer is surprisingly simple. It's not just about the raw data you've crammed into your brain. It's all about how you package it, how you present it. It's about showing you can think like a clinician, and that's exactly what we're going to break down today.
Okay, first up, the patient history. Seriously, don't ever think of this as just the warm-up. This is the absolute foundation of everything that follows. If you nail the history, you're honestly halfway to the diagnosis before you even lay a hand on the patient.
You know, the smallest words can make the biggest difference. Think about this. Did a swelling develop, or was it noticed? It sounds like the same thing, but it's not. Developed suggests it just popped up out of nowhere. Noticed, on the other hand, hints that it might have been there for a while, just lurking. That tiny detail shows your examiner you're thinking critically.
And here's a pro tip that examiners absolutely love. Instead of just jumping to centimeters, ask the patient to describe the size of a lump in their own words. Was it like a pea, an egg, a small lemon? This makes your history so much more vivid and, more importantly, shows you have great patient-centered communication skills.
Now let's talk about what's called a negative history. It's about proving what isn't going on. For example, if you have a patient with a breast lump, there are two questions that are totally non-negotiable. You have to ask about their menstrual and obstetric history. If you don't, you're leaving a massive, gaping hole in your diagnostic process.
Okay, so you've got your history down. Let's move on to the physical examination. This is where we shift from just listening to actively searching for clues. And the goal here isn't just to find things, but to present them in what we call a surgical flow.
So what is this surgical flow? It means you don't just rattle off your findings like you're reading a shopping list. No bullet points. You need to weave everything into one smooth, coherent story. It shows the examiner you see the whole patient, not just a collection of random signs.
Listen up, because this is such a classic mistake, and it costs students so many easy points. Pain and tenderness are not the same thing. Pain is a symptom. It's the patient's story. It belongs in the history section. Tenderness is a sign. It's what you find when you examine them. Never, ever confuse the two. It's a hallmark of a sharp clinician.
And when it comes to the actual palpation, there's an order of operations you just have to follow. First, you gently check for temperature and tenderness. Then, you inspect the skin over and around the area. Next, you feel for the regional lymph nodes. And last but absolutely not least, you always palpate the other side to have something to compare it to. It's a system for a reason.
All right, let's shift gears a bit and talk about precision, academic rigor. Because in an exam, being close enough is just not good enough. This is where you have to prove you know your stuff cold.
I really can't emphasize this enough. If your examiner asks you for a definition or a classification system like T&M staging, you have to recite it exactly as it is in the textbook, word for word. This isn't the time to paraphrase or get creative. They're testing if you know the global standard, and you need to deliver it perfectly.
Now it's time to bring everything together. After all that work, your final diagnosis can't just be one or two words. It needs to be a complete sentence, a full story that paints a crystal clear picture of your findings.
And there's actually a pretty funny way to remember this, inspired by the movie Damal. The professor's advice is to make your diagnosis as long and detailed as that character's famous name. It's a silly but super memorable reminder. Be thorough, be descriptive, and don't leave anything out.
So what does that long-form diagnosis actually include? Well, it needs to hit these 4 key components every time. You need the pathology, the exact anatomical site, the stage, and any complications you found. Hit those 4 points and your diagnosis will be rock solid.
All right, we are in the home stretch now. Let's talk about the final step, management and treatment. This is your chance to show you can take all that book knowledge and actually apply it to the real, live patient in front of you.
When you're asked about investigations, please do not just start rattling off a laundry list of every possible test. That's what an average student does. A great student confidently names the one best test, the investigation of choice for that specific condition. It shows you can think decisively.
And this brings us to the final, and maybe most important distinction. Avoid textbook management. That's where you just recite all the treatment options for a disease. Instead, you need to provide a tailored management plan. The examiner wants to know what is the precise plan for this patient, with their specific stage and their specific findings. That's what makes you sound like a future surgeon.
So as you walk into your next exam, I want you to ask yourself this one question. Are you just a data collector listing off facts? Or are you a clinical storyteller, weaving those facts into a coherent narrative? Because that's what a great diagnosis is. It's a story that makes sense of everything and points the way forward.